Hello, my name's Dr. Leon Creaney. I'm a consultant in sport and exercise medicine based in Manchester, UK, with clinics in Warrington and Liverpool also. This talk is going to explain to you what the specialty of sport and exercise medicine is all about, how I trained in my own career, what I do, and the nature of my hospital practice. It lasts about 20 minutes or so, and hopefully you will find it enjoyable. To begin with, I thought it would be helpful to explain what interested me in sports medicine in the first place. That's actually a pretty easy question to answer. I've been interested in sport from a very young age, football in particular, and athletics. I've always viewed sport as a fan, but also like to take part myself. I've dabbled in most sports, though running is my main thing. Moving on to the specialty itself, when I was a medical student and was coaching the university track team, many of them were getting injuries, and because I was a medical student, they would naturally come to me for advice, and I realised that I didn't know very much. It was then that I decided to go and find out, and then I made sure that my junior doctor career was geared towards a future pathway in sports medicine, even though at that point the specialty hadn't officially been created. When I was on the Royal College of Physicians Sport and Exercise Medicine Committee, we had an annual conference at the RCP, and the Faculty of Sport and Exercise Medicine has a stall, and this was the poster that I created to explain to people coming through what the specialty was all about. And you can see that the specialty is broadly split into three divisions there. Sports medicine, where we're looking specifically at sports injuries and musculoskeletal medicine, but also the peculiar medical problems that people who are pushing their bodies to extreme limits often come up against. Another factor in sports medicine is exercise for health, and this is to do with prescribing exercise for people with comorbid conditions to improve their health. And then finally, public health, which is the promotion of exercise in all parts of society. A typical training pathway for someone in sport and exercise medicine would obviously be to go to university and do their foundation years as a junior doctor. They may then do core medical training or acute care training or GP vocational training before entering a 4-year specialist programme in sport and exercise medicine. And in that 4 years, they'll rotate through accident and emergency medicine, orthopaedics, public health, and will need to gain exposure to general practice and dedicated sports medicine, and also rehabilitation and disability medicine. So usually about 8 years after graduating from medical school, you'll become a consultant in sport and exercise medicine. My own career, I'm going to explain to you now. Obviously, I did typical science A-levels, went to the University of Sheffield. For 6 years, I did an extra year of research. At that time, was interested in surgery. But towards the end of my time in medical school, that's when I really got interested in sports medicine. As a junior doctor, I rotated through the typical specialties, but always had an emphasis towards sports medicine, doing emergency medicine, orthopaedics, and rheumatology. And my first true sports medicine experience was volunteering as a medical assistant at the Commonwealth Games in Manchester in 2002. Following my senior house officer training, I was then a GP registrar based in Frodsham and Aintree, and it was then that I was able to complete both my MRCP and member of the Faculty of Sport and Exercise Medicine examinations. And this was pictures from my time at the Commonwealth Games. I didn't stay in general practice for very long at all, only 6 months in fact, and I was very lucky that the government at the time then created the first sports medicine training programme down in London. So I resigned from my safe general practice job and went to train in sports medicine without knowing really what potential career lay ahead. My first job was at the Royal London Hospital in Mile End, which had the first sports medicine clinic in the country, and I also did neurosurgery with Peter Hamlin at the Princess Grace, and did a lot of shadowing at clinics in pure sports medicine with Mike Bundy, who went on to be the England RFU head doctor. I rotated then to the Olympic Medical Institute and also did some more time in accident and emergency, and for the ride did my Part B emergency medicine exams. I then rotated to public health and then onto a very interesting job at the Defence Medical Rehabilitation Centre in Headley Court, which gave us a really good overview of sports medicine practice. I finished off my rotation by doing 9 months at the Royal National Orthopaedic Hospital in Stanmore, where I mainly did sports medicine and rheumatology. And in August 2009, completed the training programme and was entered onto the specialist register. I was lucky to be the first ever specialist registrar to compete sport and exercise medicine training in the UK. That year, I also completed the last parts of my MRCGP and was awarded fellowship of the Faculty of Sport and Exercise Medicine. You may recognise some of these faces here. These are the original 8 SEM trainees in the UK. Noel Pollock on the front row there is now the Chief Medical Officer for British Athletics, and you may recognise Eva Carnero from Chelsea. My own consultant career began in 2009. I was able to get a consultant post as a locum in Sheffield, commuting from London, as well as working 2 days per week at the Department of Health on behalf of the Faculty of Sport and Exercise Medicine, developing the first business case for sport and exercise medicine for delivery in the NHS, and also starting private practice at the Bupa Barbican Centre. I eventually did get a substantive consultant post in Birmingham. This was piloted and pioneered by Professor Sir Keith Porter, and I stayed in that post, again commuting from London for 2 years. I was very keen to work in the Northwest, however, which is home, and approached the Bridgewater Hospital and was given my first opportunity by Leslie Taylor to start a clinic there, and was soon able to convince Bupa management to open a pilot clinic seeing musculoskeletal cases in Manchester. Obviously, 2012 was a very big year in the UK, and I was fortunate enough to be a team member trackside at the Olympic Games. Highlights included 2 world records, which I was able to view from the finish line, literally a few steps away, when David Rudisha broke the 800 metre world record, and a few minutes later when the women's 4x100 team for USA broke that world record as well. Before long, Spire Manchester and the BMI Alexandra also gave me practice privileges, and I set up clinics there. I continued to work for Bupa both as a self-employed clinician and as a salaried manager until I finished in 2019. It was around 2015 that HCA also entered the Manchester market and opened the Wilmslow Hospital, and a year later the Manchester Institute of Health and Performance, where obviously I also do clinics. So, running in parallel to my hospital sports medicine, I've always worked as a travelling team doctor at events and travelling with teams for British athletics and football teams. My first event as a team doctor was at the European Cup in Annecy, and a year later I travelled to the World Student Games in Bangkok, Thailand with the women's football team. Throughout the years, I've mostly worked with the under 23, under 20 and world cross country teams, and occasionally cover the senior team at Loughborough also. This is the largest team I've ever been team doctor for, 70 athletes and 20 staff. It was the European Junior Championships. I now also work with the Paralympic team, and I've travelled to a couple of championships with them. Obviously, this is a very different experience. Many athletes with multiple disabilities, and we are due to go to the Tokyo Paralympics. I continue to maintain an interest in football and have worked with various teams, including Shrewsbury Town FC. I have done a great number of events over the years. These are accreditations from the various events that we've travelled to. Obviously, it's a very rewarding and exciting job to do, and you do get to meet and treat very famous people from time to time. So my own private practice consists of 3 branches really: musculoskeletal medicine, which other people might refer to as orthopaedic medicine; the more dedicated sports medicine with athletes and their unique problems; and also what we term exercise medicine. My philosophy in musculoskeletal medicine is to make an accurate tissue diagnosis when that's possible, and it usually is through a combination of history and examination, imaging, response to diagnostic injections, and also response to treatment. It's obviously important to elicit patients' expectations. Many of the patients who come to see to me are keen to avoid surgery, hence the reason they've self-selected to see a musculoskeletal physician rather than a surgeon. I do attempt conservative management where I think it's reasonable. However, I have no compulsion in referring early for surgery when it clearly is not the right decision for the patient. When working with physiotherapists, I usually give people a written evidence-based rehab program to follow and try and coordinate very closely with their treating physiotherapist. And we do have multidisciplinary meetings which patients' therapists are able to attend and discuss cases with us. I do have a big interest in injection therapy, and I inject all peripheral joints, shoulder, elbow, wrist and hand, hips, knees, ankles, using a combination of either ultrasound or fluoroscopic guidance. The main injectables that we use being steroids, Ostanil, and the various forms of platelet-rich plasma. I have an interest in the treatment of lower back pain, and we can be useful in helping people out with the hip-spine dilemma, for example, differentiating different sources of pain in the region of the back and groin. I do a variety of spinal injections, again fluoroscopically, chordal epidurals, usually for L5, S1 disc prolapses, lumbar transforaminals, where a more concentrated dose of steroid is required to the S1, L5 or L5 nerve roots, facet joint injections largely for diagnostic purposes, and occasionally CT or fluoroscopically guided sacroiliac joint injections. And these are just a few examples of my own cases that I've performed in recent times. One thing that sport and exercise medicine physicians I do think have a particular strength in is in the management of complex groin pain. It is a problem that often falls in between many different specialties, and there are multiple overlapping and poorly defined clinical entities. It's really important to be able to differentiate between inguinal disruption, the various stages of pubic bone stress injury and osteitis pubis, problems around the adductor insertion and pubic aponeurosis, and also differentiating between groin pain, hip pain, sacroiliac joint pain, and pain referred from the lumbar spine. I have a particular interest in patellofemoral pain and do have a separate lecture that I deliver to audiences about this. We've set up various clinics, including the Manchester Running Clinic with a specialist physiotherapist, and I have produced various educational leaflets that I do give to patients around various musculoskeletal disorders. Tendinopathy is another big interest of mine. It's obviously very important to distinguish tendinopathy from other pathologies which can present very similarly. Recently recognised problems such as intratendinous tears are often easily overlooked. There's a big role in optimizing loading regimes and also advising on return to play strategies. There are various tools in our armaments, including shockwave therapy, high volume injections, platelet rich plasma, and advising around tendon nutrition. I have a separate lecture on this also, which I do deliver to various audiences. Exertional leg pain is another big area for sport and exercise medicine physicians, distinguishing again between overlapping clinical entities, chronic exertional compartment syndrome, medial tibial stress syndrome, and stress fractures being some of the big three. There are rarer causes which mustn't be missed, and it's always important again to make that accurate tissue diagnosis. Many of these conditions will respond to a physiotherapy program, gait analysis, and a good gait re-education program. Stress fractures is obviously another big area of practice. See a lot of stress fractures, particularly again in runners. Common areas being femoral neck, the tibia, and bones of the foot, such as the navicular. Generally speaking, it's not rocket science that these fractures heal over time with rest, but there's the all-encompassing management of the athlete health around the fracture, around bone nutrition and energy availability, and making sure that it doesn't become a recurrent problem. And linked in with this, the concepts of the female athlete triad, and the concept of relative energy deficiency in sport. There's a lot of conditions that we see in athletes which aren't really prevalent in normal society, conditions which are related to extreme and high intensity training volumes. Tiredness and fatigue can be a real problem in elite athletes or even enthusiastic amateurs. Overtraining, as it's known more commonly in North America, or unexplained underperformance syndrome, as it's often termed in the UK, can be a physiological state, but can also be affected by numerous undiagnosed medical conditions and often needs investigation and optimization of nutrition. It can be seen as an injury, and the injury can be permanent, and some athletes, if not caught in time, never return to their previous level of ability. So it does need investigating by a specialist sports physician, and good knowledge of the sport, training regimes, and liaison with coaches and the athlete is important to get the athlete back to where they used to be. As a team physician, it's important to have a good grasp of sports cardiology and respiratory disorders. This is important as a team doctor. We do need to screen for conditions causing sudden cardiac death, chest pain and cardiac symptoms during exercise, and I will from time to time engage in exercise testing in elite athletes presenting with cardiac symptoms, and it can also be very helpful in differentiating cardiac from respiratory causes of exercise fatigue. We do have a role in screening and treating exercise-induced asthma, and there is a lot of involvement with sports cardiologists and respiratory physicians, for example, the Elite Breathlessness Clinic. Performance medicine is another emerging area of medicine. There can often be blurred lines of distinction between where medicine ends and coaching begins. If I was to say to you, for example, a masters athlete is complaining of fatigue and they're asking you to screen them for low testosterone therapy, would you consider therapy appropriate, and in what circumstances? We do screen for common nutritional deficiencies which athletes suffer from, and again I have a separate performance medicine talk which I deliver to various audiences. I do have an active interest in education and research. I'm a lecturer on the Manchester Metropolitan University Sports Medicine MSc, and I'm working with them also to develop an integrated BSc for medical students in sport and exercise medicine. One day in the future, I hope also to do research and do have aspirations to do a PhD and already have a number of publications to my name. In terms of media, I do regularly write articles and contribute to professional publications and newspapers, and I'm often asked for comment. I hope that's given you a good overview of what I do in my daily practice, and I now pass it over to you for questions.